Hi guys, today I'm going to be talking to you about the acute patient, what you need to do in an acute situation when a patient comes in, a bit of an overview of some of the conditions you'll be likely to see in terms of a new or existing patient coming in as acute, when to refer, and give you a bit of certainty and clarity about our role for new patients. So let me just bring up what we are talking about today. Right. Okay, I'm getting there, guys. Sorry. Give this another try. Beautiful. Like I said, what to ask patients as well, what to do with acute patients, and what to expect. So it can be really confronting when a new patient comes in or an existing patient comes in significant pain. People in pain respond differently to how they do normally. They can be very irritated. They can be very unwilling to communicate, and usually they'll be brought in by somebody else. And they can also, their loved one can also be quite distressed. So my biggest piece of advice when you see this person come in and you know that they're acute is to try and get them as calm as possible, as comfortable as possible, and everybody in the room in a state where you can start having a conversation. Now, these patients may not be a new patient. It may be an existing patient coming in for their wellness adjustment. So you may not always have 30 minutes with these patients. It can be quite scary in that situation. The patients for the rest of the afternoon or the rest of the morning will understand, but also we have to be quite efficient in what we're doing. We have to decide, are we going to refer straight away? Are we going to adjust? Do we need imaging? And you need to kind of discern that quite quickly. With acute patients, always provide an explanation of what is going on with them in terms of their body's reaction to the pain, whether they're antalgic, explain to them why they're standing over to one side, and explain to them what is going to happen in terms of looking after them. Always give an acute patient some home advice because they are going to need ongoing support. Their adjustment on that particular day is not going to be all and end all. It's going to be, particularly with some acute patients, it can be weeks before they start to feel back to their normal self, if at all. But it's really important to give them some things to do at home that they can do to help with their pain, make them more comfortable. And with acute patients, particularly if they're an existing patient, still follow up with a phone call. These patients want to know that you're thinking about them, that you understand what's going on, and you don't just, fob them off or treat them like any other patient. When they're in this amount of pain, it is really important to follow up with a phone call, let them know you're thinking about them, find out how they're feeling after their adjustment, and talk about the next time they're going to come in. So first, I'm going to talk to you about acute headaches. With headaches, the case history is the most important thing in terms of creating our differentials. You need to be thorough with your case history. What I've done here is I've done a bit of an overview of some examples of ways that we can work out exactly what's going on quite quickly by using the case history. And there's a really awesome video for all of these acute patient presentations on Thinkific. So Wayne has done a video on each of the headaches, of lower back and of acute neck. And I would really encourage you to either stop this after each section and watch that video, or make sure you watch those videos as well, because Wayne will show you not only explain the theory, but he will also go through the examinations themselves. So like I said, a quick overview. First question, has it ever happened before? Have you had this type of headache? If they had, chances are it's probably not pathological. If this is something that they've never had, the worst headache they've ever had, we're really starting to, get that red flag going in the back of our head. A blinding headache that they wake up with, or that wakes them. Again, we're thinking red flag. There's some sort of pressure in the intracranial space that's causing that blinding worst headache ever. Pressure on the top of the head is one that you can quickly and easily determine if it is in fact a blood pressure headache. Blood pressure headaches are common in terms of the feeling of pressure on their head. So grab your SFIG out and take their blood pressure. These patients you may need to refer to the GP if you do find that blood pressure is the cause of their headache. Family history will be discussed in case history as well with these patients. And if there is any vascular issues in the family, our head starts to go down towards the intracranial aneurysm path. It is possible, and we definitely don't want to just, fob off any headache as cervicogenic. The pain that patients get in the base of the skull that moves around towards their ears, this pain is also a pain that they'll describe as being worse throughout the day, and improves when they lie down. Bang, postural, awesome, this is what we can work on. But explaining to them that, it doesn't discount the fact that this could be a very significant headache for them. But with these patients, very quickly you can explain to them why they've got the headache, what you can do to help in terms of adjusting, and what they can do to help themselves at home. So some of the examinations that you'll want to do is a cranial nerve exam. So this is going to tell us where the possible pathology is. It will also tell us how much of an impact that possible pathology has had, and it will also give us a bit more information as to whether we should refer out. The cranial nerve exam, if you do find significant findings in your cranial nerve exam, we can refer patients for an MRI and MRA, or they can arrange a CT through their GP. Blood pressure headaches, like I said, take their blood pressure to confirm if they're getting that pressure on the top of their head, and their GP will help with management, whether it be that they're already on blood pressure medication or whether there's something else causing the change in their blood pressure. If it's postural, palpate those ribs, palpate their cervicals, and make sure that you adjust them. Like I said before, make sure you definitely watch the video on acute headaches on Thinkific to get some further clarification, to watch these examinations happen, and to help you brush up on your cranial nerve examination. So lower back patients. We get lots of these. You will have all seen these before. These patients can be in a lot of pain, but again, we need to get them as comfortable as possible so we can start to describe and have a discussion about their case history. So we want to know what caused the onset of this pain. Has there been an injury? How long has this been going on for? Are there any pain referral patterns? These are going to be our kind of detective skills that we'll use to build the symptoms up and to create a little bit more of a concise examination that we need to take place. A full lower limb neurological exam will take a little bit of time. It can get quicker when you practice, But again, if this is a 7.5-minute patient, if you can already have some really good information through the case history, then you can target your neurological exam for those expected nerve root issues. So this neurological exam should be done on every patient that has lower back pain, and it will be targeted based on their symptoms. So, examinations for lower back pain. Some of the kind of tips and tricks, things that can make us get an understanding quite quickly of what might be going on. If a patient is worse with extension through their back, we're thinking lumbar facet or disc. These are the patients that will want to pop into anti-gravity rather than allowing them to lie flat on the table. When they're flat on the table, it does cause extension through the lower back and it will be very uncomfortable for them. Pain that's eased with flexion, these are the patients that walk in hunched over. Could be caused by lots of things. At category 2, the lumbar facets, canal stenosis or a disc. So these patients that walk in flexion, don't just assume that they've got a disc problem. If they're better when they're still, when they're not moving, doesn't really matter what position, then we think, yep, this is pretty mechanical in nature, and you would then follow your examination accordingly. Patients who are worse when they're seated, we're thinking potential SI category 2, but also lumbar discs because of the increase in the lumbar pressure when we're seated. Other tests that we'll do with low back patients, our straight leg raise, that can also indicate issues with the hamstring tightness or sciatic nerve. So please watch the lower back video on Thinkific to see this examination done and to show how changing the slight position of your straight leg raise can determine between hamstring and sciatic nerve. A weak double leg raise, we look and we go possible category 2, and bilateral hamstring weakness, again, possible category 2. As someone who's been a category 2 before, this is not something that's just I'm feeling a bit tight and sore. Acute category 2 is pretty nasty. You can't get comfortable at all. And it is something that patients find it really hard to understand what they've done. It hasn't been from a fall. It hasn't been, most times, from a single incident. And so building up your skills in terms of explaining the way that the sacrum and the lower back changes when that category 2 sprain is going on is really important. Antalgic patients with lateral flexion. Again, this is not just disc, lumbar facet or sciatic issues can cause antalgic lateral flexion, like this gentleman in the picture. So again, just because we see a person like this doesn't mean that we're going to straight away send them for an MRI. So actions. Referring for imaging will be based on the lower limb neurological exam that you've done. That exam will make you able to target specific areas. The more information you can give for your imaging on your referral, the better. It makes us look good, but it also gives the radiologists and the radiographers, who take the image, plus the radiologists who are reporting on the image, it lets them know the area that we're concerned about, and they'll really focus on those areas. Couple of options in terms of imaging. Obviously, plain film will show bone, and we've got MRI, which is a lower dose radiation. We'd much prefer that over a CT, but CT can be done through the GP if they would like. With low back patients, adjust them. If you think it's safe, if you've done your neurological exam and you know that that they've got specific restriction in movement, we want to give these patients some relief straight away. We want to start improving the function of their lower back and their sacroiliac joints. Don't be afraid to adjust acute lower back lower back pain patients. we've got lots of techniques we can use. The anti-gravity, like I said, for those patients who come in and their pain is eased with flexion. Side posture adjusting is a really, really great way to help take pressure off the lower back. And again, there's further clarification on side posture adjusting in the video on Thinkific about acute lower back pain. Category 2 blocking, also make sure you touch up on that, because blocking someone the incorrect way when they're in acute category 2 can make them more acute. So make sure you've got your diagnostic skills right with your category 2. Make sure you know which direction that you're putting the blocks. Again, with your low back pain patient, you have to give them home advice. Let them know what they can do. Can they stand? Can they sit? Should they be using heat? Do we need to suggest Curcufort, the turmeric tablets? What do we suggest? And we've all got our really great knowledge on things that they can and can't do. Don't let them suck you into, oh, but I really should, I've got to work tomorrow. Oh, I've got a grand final tomorrow that I really need to play. You need to give them the information based on what we've learnt, our extensive knowledge in terms of our degrees, and don't let them talk you in or out of allowing them to do anything. You give them the information, then it's up to them. Acute neck patients. These patients tend to be quite distressed because often they can, this is something that happens quite suddenly. Most common acute neck is a torticollis. But again, our case history is the most important thing to create our differentials. Like I said, our torticollis patient, this will be, they woke with the pain or it came on spontaneously. There's an acute spasm of their cervical musculature and their head is often antalgic to one side or restricted movement to one side. Other acute neck patients, they could have had a fall, they could have had a whiplash injury, they could have had a car accident. These patients could have possible structural injuries, and we need to refer them out for current films. The other thing that can cause an acute neck is the reflexogenic muscle spasm after an upper respiratory infection, someone with a sore throat, sinus issues, an ear infection. So don't forget in your case history, ask them about how they've been in the last 2 weeks. Have they had any of these upper respiratory infections? Could be caused, the neck pain could be caused by a reflexogenic muscle spasm. Treating these patients, 9 times out of 10, we will palpate their first ribs and upper thoracic ribs, and they will be locked. They will be tight. They won't have been moving properly. With a torticollis patient, make sure you adjust them. They will thank you for it in 24 to 48 hours time, often even straight away sometimes. These patients we do need to adjust, but you will have to adapt the way that you adjust them according to their ability to move their head. Standing ribs are great because we can free up that first rib movement, that rib cage movement, and free up the bottom attachment of those cervical muscles. And adjusting first ribs, you can do it manual supine or prone drop piece if you can't get them into that position. Again, these torticollis patients or the tight neck patients who we've ruled out as having any structural issues, give them home advice. Heat is really important to stop the muscle spasm, and PNF muscle contractions exercises every half hour will help to stop those muscles from maintaining that constant contraction. Again, please watch the acute neck video that Wayne has done on Thinkific to see this all in action and to have further clarification. So the last section I'm going to talk about isn't specifically, something that we would expect to see as chiropractors, but I have seen from time to time, and I know you guys will have too. Some patients will come in and they could have a break. They may have had an injury or a fall with or without swelling. So sometimes they might come into you with a really tight shoulder and neck, but they've fallen onto their arm. We do need to check and make sure that they've got no breaks. In the hands and the feet, breaks can go undetected. Clavicles, breaks can go undetected. And we really, as primary healthcare practitioners, have a responsibility to check these patients out, but we also have the skills to do so. So again, like all the other acute patients, and like every time a patient comes in with something a bit unusual, take a really good history. If they're in significant pain, that's a sign that we need to delve further. Check with your tuning forks. That's what they're there for. What we learnt to use them for at uni is to check for any sensitivity to vibration. This can indicate a fracture and would give us the information that we need to make sure that we refer them on. Again, as primary healthcare practitioners, we need to practice the PRICES acronym when a patient comes in. Even if it's something like a sprain or a strain injury, we need to give them advice on the PRICES. So protect, rest, ice, compression, elevation, and I can't remember what the S stands for. Isn't that silly? Give me one moment. So the other thing is we do need to refer these patients out for x-rays if we think that that's necessary. Again, be specific about what you're asking for in terms of, because the better the information that we give the radiologists, the more that they will kind of go into the specifics about the area that we want adjusted, the area that we need imaged. Excellent. And the reason I can't remember the S is because there is no S in PRICES, it's price. So protection, rest, ice, compression, and elevation. S is for silly, Mon. Patients with acute injuries to their limbs, you know, we can offer a lot of support, but we do need to refer these potential breaks out for additional support. So what all this means, these people in significant pain do need to be assured that you know what you're doing. We also need to be sympathetic with them about their pain, but confident in the same respect. We can't just stand up and be an authority and talk over them when they're saying how this is affecting them. We do need to be sympathetic, but don't go into a state of full sympathy without giving them support and advice. Keep practicing your examination skills. These things you don't want to do for the first time in 12 months with an acute patient. So, you know, pull out your stethoscope, pull out your SFIG, take blood pressure on patients for a couple of days, do a lower limb neurological exam, do a cranial nerve examination, practice these skills so when an acute patient comes in, you're really confident in what you're going to do. Keep your examinations based on your case history. Be quick, but thorough as well. You know, we don't want to be spending 2 hours examining these patients. Be vigilant for red flags. At uni, we're taught to really watch out for these, but don't let that stop you being a chiropractor. We adjust patients when we know that it's safe to do so. We're very skilled in adapting our adjusting skills to make sure that it's safe and effective for patients, depending on what they come in with. So please don't let the red flags stop you from adjusting, but keep your vigilance. Always provide the explanation of what's going on. So based on your examination, tell them what you think is happening. They want that reassurance that you know what's going on with them, and that you can explain it to them so they understand. Always provide home advice for pain management, and explain clearly if you refer out what you actually need that patient to do. Just saying, here's a referral for some x-rays is not enough with an acute patient. You need to explain how they go about it, where they need to go. Same with their home advice. Don't just say pop some heat on. Give them a prescription of heat, whether it's every 30 minutes, whether it's alternating heat and ice, 10 minutes each with 10 minutes in between. Make sure that you give them a prescription and really write it down if you've got the time and if you can, because patients who are in acute pain are unlikely to remember what you've said. And again, I will reiterate, please always follow up an acute patient with a phone call, because it shows that you care, it shows that you understand, and it will help you when you see them next to know how they've reacted to their adjustment. That's all in terms of the acute patients, guys. If you have any questions, feel free to contact me or put them up on the Thinkific discussion board. I hope this has given you a bit more information as to what to look out for. Please, please, please don't be afraid to adjust. Don't be afraid to look after these acute patients. It can be scary seeing a patient in a lot of pain, but we can make a massive difference for them. And it is really important that we do our examinations quickly, we take our case history quickly, and we get them feeling better as quick as possible. Thanks, guys. Take care.